Information gained from viewing the following program is not a substitute for regular exams by your physician and does not constitute a doctor-patient relationship. All information gained should be discussed and confirmed by your physician.
Welcome to Healthy, Wealthy, and Wise. We're so glad that you've joined us today. We know that you understand that health is your greatest wealth, and so we hope that we can combine that healthy, wealthy, and wise. And I'm delighted that my wife Beverly, my co-host, is with us today also. We're going to have a great topic to discuss with you because one of the greatest problems we have in this country, health-wise, is one that's a sleeper, our sleep problems. These health principles that we're going to discuss today will apply to everyone, but there'll be some of you that will be especially interested because you've had problems in these areas yourself. I would suggest that you get a pencil and a piece of paper perhaps. You may find something that you hear today you'd like to take some notes about, maybe some websites that you'd like to access. So have something handy in case you want to learn a little bit more about what's going on. Our guest today, we're so delighted that Dr. Ralph Downey has joined us. He's the chief of the Sleep Center here at Loma Linda University, an associate professor of medicine. He's had many years experience. I think you said 25 years here at Loma Linda, something like that.
A long time.
Yes, well, that gives you great experience, and we know that it's been a time where you've been able to help a lot of people.
Thank you.
Because sleep is a problem for so many of us, I was going to ask Dr. Downey what really normal sleep is, and maybe first of all you could tell us how many people in this country seem to have sleep problems.
Well, that's a very good question because I think as a percentage, probably about half of your viewers, as a percentage, probably have some problem with sleep, whether it's a small difficulty with getting to sleep, a night to night here and there, or whether it may become a bigger problem, such as as we'll talk probably more about, sleep apnea, where it can cause difficulty with breathing at night and difficulty with heart function. So there's 84 sleep disorders.
Oh my, we won't have time to talk about all of those today by any means, will we?
I don't think so.
So what is a normal sleep pattern as far as the time, the number of hours, the time of going to sleep, and tell us a little bit also about the beginning and the persistence of sleep.
Sure. When we first initiate sleep, I think when we're growing up, we're kind of taught that it's like an on and off switch, but really sleep is something that is more like a dimmer switch to a dining room where you sort of slowly ease into sleep. And as we're drifting off to sleep and we're just about ready to go into sleep itself, we have a drowsy period. We call that stage 1 sleep on the EEG when we're looking at things from a sleep center standpoint.
So you study electroencephalogram as people go to sleep, and that tells you a little bit about how they're making the sleep work.
Exactly. So that's our objective measure of sleep is looking at an EEG. A similar subjective experience that you would have at that time would be the feeling that perhaps the eyes are kind of rolling in the back of your head and you're kind of losing a little touch with what you're reading and maybe you've missed a paragraph. That's sort of the initiation of sleep. And of course later as we get into stages 2, 3, and 4 sleep, which are deeper stages of sleep and are again defined by the EEG itself, we're more likely to experience those as deep sleep. So if you were to give me a call and I were in stage 2, 3, or 4, I'd wake up and maybe forget that we'd even talked. Probably be a little groggy.
And probably be a little upset that I got the call, too.
I'm wondering, what are you calling this time of night for? And then last but not least, of course, is dream sleep, or rapid eye movement sleep. And that's where about every hour to hour and a half, we have a dream. And as the night goes on, the dreams get longer, a little bit more fantastic. And if you were to wake me up then, give me the same kind of phone call, I would probably remember being in a dream. And most of us don't remember our dreams every night, but we do dream pretty much every night. And so that's kind of the cycle, and it repeats itself about every hour and a half. We have 3 to 5 of those every night if we sleep for an average, say, of 8 hours, which is about the average.
So most of us will get about 8 hours sleep. just in the natural course of events.
Right.
But if we're getting like 5 hours sleep, is that something detrimental necessarily?
Well, it's a really common question I get from patients, from folks in the grocery store, wherever I am, and I happen to mention what I do. But I have to tell you that the average is misleading. It's kind of like Mark Twain once said of an average. He's between a man and a dog. And he said the average is 3 legs and half a tail. And it's kind of like that. With sleep, and what is good for you and what isn't good for another person differs. So the average, while 8 hours, is a little misleading, because you could, for example, get by with 5 hours, and as long as you're doing well during the day, you're not having problems staying awake, interviewing people, such as sleep specialists, then that's probably enough for you. If you, on the other hand, are sleepy, even if you're getting 8 hours, but at 9 hours you're alert and fully functioning and not falling asleep, then it's 9 hours. So it varies.
When you were discussing these stages of sleeping, you mentioned about the dreaming. During which stage do you get most of the dreaming time?
That's in REM sleep. Sometimes we call it stage 5 sleep, but REM sleep stands for REM, or rapid eye movement sleep. And that's when about 90 to 95% of our dreams occur. Other times we can dream, but we don't usually have that fantastic dreamlike experience, for example, in stages 2, 3, 4. If we remember anything, we remember sort of thinking about our bills that we need to pay. We remember sort of bland stuff. So it's not the dreaming that we tend to associate with flying and having a good time, and then unfortunately in some cases nightmares.
But those, then, is that part of the sleep where you're dreaming a lot, is that considered to be deep sleep, really, at the 5th stage? Is that down at the deep?
Actually, that's a good question, because most of the time people think that. But the deeper stage is actually 3 and 4 sleep.
Okay.
So when we're a little more easily roused out of our dreams than you might imagine. So for one reason that may also be true is the fact that our longer dreams tend to occur later in the night. So if our alarm goes off a little earlier than we expected, chances are we're going to have our biggest dream, interrupted. That's also the time when we're most likely to remember the dream, is when it's interrupted. So we kind of two go hand in hand.
I see.
Yeah, so it's we're not as groggy waking up out of REM sleep. So it's good to wake up and start your day out of a dream.
The rapid eye movement sleep. Is there a genetic relationship? I mean, some things kind of run in families?
The length of sleep tends to be a genetic thing. There's actually a very interesting book. It's kind of an extreme example of the genetics, but there's a genetic condition called fatal familial insomnia. And there's a book written now about that condition. And in that condition, it's a prion disease, or a protein related disease, and there's a clear genetic connection there. With sleep apnea, where you stop breathing at night and you have a difficult time with that, it tends to run in families as well. So there's a connection there. And one other condition where you see the genetics playing a fairly significant role is narcolepsy, where patients or people just have difficulty staying awake. Suddenly they have a real rush of sleepiness.
In the daytime?
In the daytime. And it's not the kind of cartoon thing where you just knock off and go to sleep, but they're very sleepy. Yeah, so that tends to run in families as well.
And one other quick question relative to the age. In other words, in the younger in life, the kids, and then as you go on into work stages, and then maybe into retirement, is there a major difference in the number of hours you need during those times?
And it's a very good question, because the first big shift in the amount of sleep time, of course, is from when we're very, very young to when we're young children, say 2 or 3, where we start working our way out of the need for napping. But the biggest first milestone is adolescence. And when, for example, high school kids, they tend to go to bed later, need a little bit more sleep. But unfortunately, school starts earlier, so they get less sleep. So they kind of like our automatons walking to school with less sleep. So that's our biggest shift. And then later in life, it's hard to say exactly the age, but say the 6th decade of life, when we tend to get a little less sleep because we sleep less deeply. So our rhythm, our circadian rhythm, which is sort of is one of the things that drives our ability to stay asleep, it's our cue to go to sleep, it's our cue to wake up, tends to flatten out. So we tend to take more naps to make up for those as we get older. So it's not as big of a shift as maybe it's portrayed, but when Grandpa's taking a nap in the chair watching television, it's probably a good thing, making up for a little lost time at night. So I think those are the major changes.
Is it possible for a person to get too much sleep?
If you take too long of a nap, you ever had that experience where you just kind of feel like you're climbing out of bed, and if you could, you just sleep for another 3 hours? That happens if you're taking a nap. For example, you're trying to catch up a little sleep, kind of trying to take a power nap. But a power nap is only powerful if you keep your sleep to about 20 or 30 minutes. If you get past that, you enter the slow wave sleep that we talked about, and we were chatting about earlier. And that's where you get that sort of grogginess that I wish I wouldn't have even taken the nap sort of sleep. So in that sense, you can. And then the other side of it is if you sleep in and you don't get your day started, it's sort of like the law of inertia. A body in motion tends to stay in motion, a body at rest tends to stay at rest. It's kind of that same principle.
So I'm sleeping 12 hours a night. That may be not as beneficial possibly as 8 or 9 hours of sleep.
If you're sleeping 12 hours a night and you're waking up and you're feeling good, but if you sleep less than that and you're waking up and you're feeling poorly, then you need the 12 hours. The problem sometimes is we have to separate also, are people spending 12 hours in bed sleeping, or are they spending 12 hours in bed and sleeping 9 and then saying, my sleep's fragmented, I don't know why I sleep so poorly? And this is a common experience we run into with insomnia. Is patients will stay in bed thinking that rest is better than no rest. And unfortunately, we have to sort of unlearn that response. Otherwise, they get frustrated and just want to stay in bed longer and longer, and pretty soon it's not efficient at all.
All right. You talked about the different stages of sleep, the 3rd, 4th, 5th. Is it a problem to get too much of one of those stages or not enough of stage 3 or 4?
The key has really, research has shown that the stages of sleep, which are, we have to remember, kind of man-made in a sense, woman-made too, in the sense that in 1968 or so, a bunch of folks in sleep medicine sat down and said, you know, we're going to call this stage of this 30 seconds of paper that goes by on an EEG, this is going to be called something, and we call it stage 1 sleep. By the EEG itself, stage 2 or 3 or 4 sleep. The body doesn't know that it's cut up that way for the purposes of communication. What's important, however, is the fact that it's continuous. Our sleep needs to be continuous. And however I break that up, if I were to give you a phone call like we chatted about earlier, that maybe you wouldn't be too happy with, but if I gave you a phone call every minute during the night, it would be as if you didn't sleep at all. It's kind of like rebooting your computer over and over and over. While that's an extreme example, that does happen in some conditions, but it's that, again, it's that continuity of sleep that's the key. It's not so much one stage or the other as much as we've been told, perhaps.
Sure. Does everybody get stage 5 necessarily?
The REM sleep? Unless there's a medication that you're taking, you should be getting that the REM sleep. Some people get worried that they're not because they can't remember a dream, but there's just individual differences in how they remember dreaming, and that trace for that fantastic material we dream about, unfortunately, is lost, and it somehow seems wrong that we would have such fantastic dreams, but yet they're just lost.
Sure, sure. Is there anything that I can do to get a really good pattern of good sleep without medication? Do you have any suggestions?
Sure. The key to sleep, as it is to most of life, is keeping things consistent. The brain loves routine, and it's so true for sleep. If you do, when we're young, we can kind of get away with monkeying around with our sleep a little bit, stay up studying late and get up early and we can get back to sleep. But as we grow older, it's a little harder to do that.
Right.
So I think that the number one thing is to go to bed the same time, to wake up the same time every day. If you do that and nothing else, you would probably benefit greatly from that. So most people that do that can get along well. And of course, stay away from the things that we know interrupt sleep and cause bad sleep, and that is caffeine,
Right.
tobacco, and so on.
Right.
But exercising, I know you love tennis. That's a great thing. And those are important aspects too. And to exercise, again, the same time of day
Oh, good.
is important. So just try not to exercise. Do your ultimate tennis match right before you go to bed, and then you're worrying about the tennis match and you're sweaty. So that's probably not a good thing.
So exercising just before going to sleep isn't the greatest idea.
Not the best idea. It isn't completely out of the question if you exercise in the evening, but just not. My rule of thumb is 2 to 3 hours before bed should be your last time of exercise. I don't have all that much data to support that from some grand study somewhere, but it's kind of it's becoming more like a commonsensical idea. But one of the things I've found is there's sort of two types of exercise people, the morning people and the evening people, and they don't understand each other. And one group tends to like to get rid of all the stuff that's built up, the stress of the day, and the exercise in the evening does that for them. The others like to say, I can become more hardy, if you will, to the stress of the day if I exercise. So when I get up in the morning, I'm ready to go exercise. And, you know, everyone swears they're going to get up in the early morning and exercise that are evening people, and then when the morning comes, they're sitting there thinking, why did I even say it? So there's two different kinds that way, but as long as you keep the separation between the time to go to bed and the exercise, maybe 2-3 hours,
2-3 hours.
You're probably okay.
Well, how about exercising the mind? Is that a similar situation? If you're doing something a little bit too intense or worried or maybe having an argument? Or well, I'm not sure that's exercising the mind in the right way.
I was going to say, well, reading a book that you love, or a book that is somewhat neutral, maybe not a Stephen King novel or something right before you go to bed, is probably okay. In fact, some people tend to read just to kind of put their mind in a different place, kind of cut their mind off from the stresses of the day.
Oh, I see.
And that's probably a good thing. So it's not too bad. I wouldn't probably open your mail and try to go to sleep.
Don't look at the bills anyway.
Yeah, don't do that.
Well, if sleep is inadequate, somehow you don't feel rested enough, or maybe you're having this daytime sleepiness, and maybe you've even almost nodded off at the wheel driving a car, for instance, without being awake all night the night before, but this just gets to be a habit. When this inadequate sleep is the case, what do we do about it? How do you attack that, and how does it affect your health?
Well, the sleepiness aspect of life is probably, if I were to guess, about 8 out of 10 of the patients that come to the sleep disorders clinic are sleepy people. I think most people think, well, we'd see 8 out of 10 would be insomniacs, but it's actually the other way. So this is a very, very important point, because first of all, society itself is sleep deprived. We know that by looking at the diaries that were kept before the light bulb was invented. People slept about 2 more hours than they do now.
Interesting.
So now, as you mentioned, we have not only books to compete with our sleep, we have the light bulb, which Thomas Edison gave us. Thank you. And he didn't need much sleep, I might add. And we have the internet, and we have movies. We're a 24-hour society.
We're bombarded.
We're bombarded. So we have to make that decision at some point. It's time to go to sleep. But if all that seems to be okay and a person is still sleepy, then I recommend that they see a sleep specialist or their primary care doctor, because that's a signal, that's a symptom that something's not right, that the sleep you're getting isn't of the quality that it should be. So either the fragmentation that we chatted about a bit, or there may be, the fragmentation may be coming from a sleep disorder, particularly sleep apnea, and that's a problem.
And you said there's scores of different kinds of sleep disorders, but I guess sleep apnea may be one of the more important ones and one of the most common.
It's the one that always is the tip of my tongue, because of the fact that what sleep apnea is to remind our viewers, is where you stop breathing for 10 seconds of course, during sleep, and or longer by definition is what we call
But
an
you wouldn't
apnea.
know that yourself.
But you don't know it. In fact, the last person to know they have sleep apnea is usually the apnea patient. They're usually in our office because they said, well, my wife said I needed to come, and I'm here to prove that I really don't have any problems.
Because she can't sleep
yeah,
either.
Yeah, they're sleeping great. If you ask a sleep apnea patient how they sleep, they say, great. I sleep in traffic, at a stoplight. I sleep everywhere. And the problem is that all these events, all these episodes where they stop breathing, their brain eventually signals their body to create an arousal from sleep, and it fragments their sleep in order to breathe again. So there's a functional arousal to this whole process. The brain can't go on and on with these apneas for long periods of time, so it sends a signal to the dilator muscles, hey, wake up, and the brain has to send a signal and open the airway.
So it's a protective mechanism to keep you from dying while you're not breathing. And apnea means no breath, no oxygen.
Exactly. And if we didn't have that protective mechanism, we probably would die in our sleep. The downside is, over time, that protective mechanism backfires a bit because then we become sleepy during the day. So then our number one risk factor or number one downside to having sleep apnea is maybe crashing our car. So because we know sleep apnea patients are more likely to have difficulty staying awake when driving or doing other things. And so it becomes a real significant problem for them.
Now you're affecting the lives of others.
You're affecting the lives of others.
I thought it was mostly people that were quite overweight that had sleep apnea, but apparently that's not the case.
Yeah, you know, that's the interesting thing is when, I guess you mentioned 25 years ago, it's hard to even say those numbers now, but 25 years ago, that's about the only type of patient we saw was the young man or middle-aged man with the short, thick neck and overweight, and that was the stereotypic sleep apnea patient. Now I'd say 7 out of 10 of our patients are overweight and have similar anatomical features, but 3 out of 10 aren't like that, and it's interesting because it goes back to what you asked earlier about the genetics, and I wonder, is there a stronger genetic component to why our airway closes, even though someone may be young, able, and thin, and yet they still have sleep apnea. So it's not some old person's disease or some one type of person's disease. It's unfortunately a problem that can affect all of us.
So who should be tested for sleep apnea? Who needs to go to the sleep center and see your team?
See our team. Well, there's 3 S's that I like for folks to remember, and maybe since people were reaching for pens earlier when you introduced the show, they can reach for one now. The first S is sleepiness. We talked about that. That's the key. First of all, is the patient sleepy? Secondly, does the patient snore? So there's the second S. The third S is a little harder to remember, but does the spouse say that you stop breathing? Or maybe you could say stopped is the third one. So anybody who has 2 out of those 3, I think, should come to the sleep center because those are key things. So if you're sleepy and you snore, you come. If you're sleepy and you stop breathing, and at least you're told you stop breathing by others, you should come. And as you said earlier, it's a very important point. Apnea patients don't remember waking up short of breath. Like you might imagine everybody would feel that way, but they don't. That's not we don't hear that very often. Unfortunately, you'd think that'd be a quick cue and we'd all get better, but it isn't.
We could probably do a whole segment just on snoring. Is it true, though, that you can have a partner or you can be snoring but not have sleep apnea?
Sure. Yeah, very, very good point, because sleep apnea occurs in, say, 30% of the population at most, and I think that's high, but say 10 to 30%. But it's considered snoring occurs in between 30 to 50% of the population. So if we brought every snorer into the sleep center, which would be a line as long as you can imagine to get a study, that would probably be overly done. So clearly people snore that don't have sleep apnea. The key is, are you snoring in every sleep position? Are you snoring every night? Is it loud? And as one of my patients once told me, they have 3-door snoring. I said, what's 3-door snoring? He says, well, first I moved one door down and they could hear me. then 2 doors, and now I'm 3 doors down. So I have 3 doors snoring. So I think if you get to like 2 doors, that's probably not good.
Probably time to do something.
It sounds like snoring through a megaphone or something. So what's the best treatment for snoring then? And let's address the sleep apnea part really, because the snoring will take a lot longer. But what's the best treatment for that?
It's still, as much as people don't want to hear this, I think, who have sleep apnea, CPAP is still the best thing. And CPAP is really an abbreviation for continuous positive airway pressure. And what it amounts to is the airway closes, and we need to pop that airway open like a balloon. So the CPAP is a mask attached to a device that pushes air through the mask and through the airway and pops it open. And so what we do in the Sleep Study Center is we actually figure out what that pressure is that's needed to open up the airway so that you stop, well, you breathe well again, and you don't have snoring. So we try to do both with that. And it's still the most effective thing we can do. Before that, we had to use tracheostomy as the only means in severe cases. And there are other things too, but CPAP right now is still the #1 thing. Surgery to correct the upper airway redundant tissue, to remove that, can help about 4 out of 10 patients. The problem is we don't know which 4 out of 10 it might help. And that's a real conundrum. And last but not least is oral appliance therapy. Some devices can be fit so that it moves your jaw forward and keeps your tongue from impeding the airflow. So,
Well, it sounds like it's a pretty complex area. But I would encourage our viewers to be sure that if you're having trouble with daytime sleepiness, that you talk to your doctor about it, get a referral, get the sleep apnea test, because it can make the difference between, frankly, folks, between life and death. We're finding that people with sleep apnea have more heart problems and more high blood pressure. So thank you so much for joining us today. We hope that you've enjoyed Healthy, Wealthy, and Wise. Our prayer for you today is that you will prioritize these principles for good health and for sound sleep, apply them to your living, and remember that a merry heart doeth good like a medicine. It may even help you sleep better if you don't have all those worries to boggle your mind. And then remember, you can find us on the web at llbn.tv. Tell your friends about us. Healthy, Wealthy, and Wise comes to you through LLBN weekly, on almost every day of the week. Look it up on our website and see when we're again going to be there for you.